Hello, good evening. Today, back to our discussions. We will go through Paediatric Surgery, eMRCS, MCQ. We'll go as every time. If you want, just read question and we will discuss the answer and illustrate the related questions as well. Okay, so let's start. Our first question, Dr. Basharat. Okay.
Yes. 1 minute, please.
Okay, start.
Okay, I'm ready. A 3-year-old boy is referred to the clinic with a scrotal swelling. On examination, the mass does not transilluminate and it is impossible to palpate normal cord above it. What is the most likely diagnosis? A. Hydrocele. B. Direct inguinal hernia. C. Indirect inguinal hernia. D. Femoral hernia. And E. Lymphatic malformation. As it is a 3-year-old child, and no transilluminance, and it is impossible to palpate normal cord above it, it is an indirect inguinal hernia.
Indirect inguinal hernia. Yes, exactly. So, okay. Here is a question is talking about a child, 3 years, has a scrotal swelling. We have in scrotal swelling for children's two options or two common surgical diseases mostly we face, and the most common, I'm talking about the most common. Okay, the first one is inguinal hernia, and this is because the internal and external ring and indirect inguinal hernia, to be more accurate, because there is no direct inguinal hernia in infants. We mostly find it indirect through the inguinal canal, because here the internal and external ring will be in the same line above each other, and there is no or very short inguinal canal. Okay, so we have two things. The process vaginalis is completely patent and open, and this will allow peritoneal fluid and intestinal contents go through the patent process vaginalis through the scrotum. So you can't feel the testis, or sometimes you can feel it, but if it's completely down, it will be separated from the contents, but it will also be hard to feel it. The other thing is hydrocele. The hydrocele here is the process vagina is completely obliterated, or at least it's very narrow to get through any intestinal content, get through the canal or the process vaginalis. So you can find just peritoneal fluid. That's why he said it is not transilluminated. Okay, so if we just have draw scrotum like this, and we have two options. We have even the process vaginalis is very narrow or obliterated, and then here is hydrocele. So this will be fluid. So by torch, it will transilluminate. The other is very wide, which allows intestinal contents to go through and try to illuminate, so no transillumination. So this will be hydrocele, okay, and this will be indirect inguinal hernia. Okay, clear? Okay, Next question. Whose turn? Dr. Farah, okay.
A male infant born at term appears well following delivery. 6 hours later, he is noted to have bilious vomiting by the pediatricians. On examination, he seems well. His abdomen is soft and non-tender. What's the best course of action? Arrange an abdominal X-ray, undertake a test field, perform serial abdominal examinations, arrange an upper GI contrast study, arrange a laparotomy. I think it should be arrange an upper GI contrast study.
Okay, what do you expect as a problem here?
Maybe the patient has a malrotation of gut.
Yes,
and
exactly.
That can lead to bilious vomiting.
Exactly.
Initially, the patient can have a soft abdomen. It can be non-tender also, but eventually
Yes.
the findings can be different. So to rule out malrotation of gut, we need to do upper GI contrast study. In addition, we should also do USG abdomen to complement this.
Okay. Exactly. Here is the problem. Mostly will be sinus malrotation or volvulus. Okay. We have two causes of biliary vomit. Okay. Most of them will start in the few hours or few days after birth. According to the eMRCS here, he said that internal malrotation will appear from the 3rd to 7th day, but here in our scenario, he just asking, he told 6 hours later. But in duodenal atresia, in the first few hours, will be manifest the patient with biliary vomiting. So in biliary vomiting, we have two options. Duodenal atresia, which will start few hours after birth and later within 3 days, or we can start with few hours up to the first week of life. We will have what's called intestinal malrotation. The other problem in child in vomiting, which is the non-bilious vomiting, and according to our schedule here and our questions in eMRCS, it will be pyloric, congenital pyloric stenosis. Okay.
Yes, sir.
I just want to have one photo here about the, yes, this one. Causes of bilious vomiting in units. What we will have more in our question is number one. Number one and number two. Okay. Others we will not face in vomiting, even if meconium ileus. It will be mostly abdominal distension, delayed passage of meconium. We will have different question, but about vomiting, we have the first two. This is the most common we will face in our questions and most common scenarios, even in recalls. Duodenal atresia, which happens few hours after birth, and contrast study, double pupil sign is very common in questions, and contrast study is the most common investigation upper GI contrast study. It's the most common investigation we do. And our treatment will be duodenoscopy. Duodenoscopy. The other scenario will be intestinal malrotation. Okay, and we just from the 3 to 7 days, most common. So he will tell you the child went home and in the second day, third day, or back after 24 hours have a bilious vomiting. So that will be malrotation with volvulus of the gut. Also, we'll go for upper GI contrast study. And very important to know about the treatment option, which will be LADS procedure. LADS procedure, okay? This is very important, and this is the most common questions we will face in our scenarios about bilious vomiting, okay? The non-bilious vomiting, we will face it during our question, I think here also as well. This is the non-bilious vomiting. Most common question will come with pyloric stenosis, and it's very common to go for from 4 to 6 weeks. I think I faced one question, it's about 2 weeks. 2 to 6 weeks will be more accurate because I faced one condition with 2 weeks. But before the first week, it will be intestinal malrotation and it will be bilious vomiting.
Duodenal atresia.
Duodenal atresia. Duodenal atresia in the first few hours.
Exactly.
Malrotation from 3 to 7 weeks. 4 to 6 weeks of life, it will be non-bilious vomiting and it will be pyloric stenosis. And by the way, there is a family history maybe. But the most important question we will ask about is test feed and ultrasound. Okay, and our treatment option is Ramstead pyeluromyotomy. Okay.
Okay.
Now it's clear. Duodenoscopy for duodenal atresia, LADS procedure for malrotation, Ramstead pyeluromyotomy or pyloromyotomy. Sometimes he tell you pyloromyotomy, but he will get it. He will just mention it Ramstead. This is for pyloric stenosis, and don't forget test feed and ultrasound is its diagnosis. And you can see during test feed, what will you see? You'll see abdominal peristaltic movement in the upper right quadrant, or at the upper half of the abdomen, you'll find peristaltic movement of the stomach and pylorus. Okay.
Yes.
Is it clear about vomiting in pediatric issue? Others like acute appendicitis, you'll find child more than 3 years. By the way, the most common surgical problem in a child less than 1 year, you will start with inguinal hernia or hydrocele, and this is the most common surgical pediatric problem in the first year. Me as a surgeon, I see it many times in many childs. From the first months, 2 months, 3 months, you'll find patient with hernia. Mostly will be, I'm talking about surgical emergency. You'll go through operation. This will be inguinal hernia or hydrocele, because umbilical hernia, according to the Royal College and according to the NHS, they don't interfere before 3 years if uncomplicated. So you can see many children with umbilical hernia, but you don't interfere. I'm talking about the emergency, so it will be inguinal hernia. The second problem you will face from 6 to 9 months up to 1 year is the interception. Okay, so a child less than 1 year. Why are we talking about child about 6 to 9 months or 1 year? This is related to introducing new types of food for the child. Most pediatricians start to introduce new foodstuffs for children at after the 6 months. Some say you have to absolute breastfeeding for 1 year and others for 2 years, but maybe in most countries, as a child completes 6 months, and nowadays maybe up to 3 months, they start to give new food stuff like some vegetables, some fruits, some rice, and something like this. And this is actually will be something like strange stuff for the intestine, which will start to react, start to have peristaltic movement. The child start to suffer from some colic. So very common to see this problem in children, that they start to have intussusception. And the most common which will be the ileocolic or ileocecal intussusception. Okay. The second year of life, the most common surgical problem will be in pediatrics. Mostly will have the Meckel's diverticulum. I'm talking about surgical problems. Meckel's diverticulum will face it mostly after the first year, so it will be in the second year. And then after 3 years will be appendicitis. Okay?
Yes.
Clear? Okay, so let's go through the third question. Who's there? Dr. Ibrahim, تفضل.
Yes. A 6-day-old baby was born prematurely at 33 weeks. He has been suffering from respiratory distress syndrome and has been receiving ventilatory support on NICU. He has developed abdominal distension and is increasingly septic. Ultrasound of the abdomen shows free fluid and evidence of small bowel dilatation. His blood pressure has remained labile despite inotropic support. What is the best course of action?
What do you expect the problem here?
There is sepsis. It was a syndrome, happens in premature, but I can't remember its name.
Yeah, not syndrome. It's a very common complication in premature infants. And he's septic. He has free fluid and evidence of small bowel dilatation.
I guess the
And
answer will be laparotomy.
Yes, exactly. Okay, I did see many answers. Yes, necrotizing enterocolitis. Okay, yes, very common here in asking about pediatric problem, as he mentioned premature child and has an abdominal problem and sepsis. Put in your mind necrotizing enterocolitis. We will have many questions. Whatever the scenario will go, as he asking about the problem happens for premature infection, child, few weeks, not full term. He is asking and he want to test you about what is the problem. So we have 3 scenarios here. Okay, the first scenario he want to know what is the problem. What is the problem? The problem is necrotizing enterocolitis. Okay, this is the first scenario we'll face. The second scenario we will face is managed medically. Okay, most cases, more than 90-95%, we will go medically. Okay, laparotomy in complicated cases. Okay, what means by complicated cases? Increasingly septic, free fluid, that means there is intestinal perforation or air under diaphragm or thumbprint appearance or gas through the abdomen or air fluid level or something like this. Any complications, the patient is going septic in spite of medication, in spite of ventilation, in spite of antibiotics, and in spite of supportive treatment, the child is still septic. So he wants to tell you, or he wants to know from you, that you will go for laparotomy. So this is our 3 scenarios about a premature child. Okay. Chirocolite managed medically, if about 90%. If responsive, you will go for laparotomy. Okay. Let's go question by question and we will illustrate everything. So who's next?
A female patient is born by cesarean section at 38 weeks gestation for fetal distress. The attending pediatrician noticed that she has single palmar crease and prominent hypocantic fold of the eyes. Soon after the birth, the mother tries to feed the child, who has projectile vomiting about 10 minutes after feeding. On examination, she has a soft, non-distended abdomen, but is the most likely diagnosis. Female palmar creases is mean Down syndrome.
Yes. Perfect.
Projectile vomiting. Yes,
what is the most common projectile vomiting after birth we mentioned a few minutes ago?
Untitled Atresia, yes.
Perfect. So if you don't know the case, or just he want to tell you, but just he want to tell you the patient is Down syndrome or Mongol, prominent epicantic folds, single palmar crease, and you just go for, he want to tell you these child are very common associated with duodenal atresia. If he didn't mention, we know now that a projectile vomiting few minutes after birth, it will be associated mostly with duodenal atresia. Okay. Next one, 3 days to 7 weeks, it will be intestinal malrotation, or he will tell you the child went home and back after 24 hours, or the second day, or after 2 days. You will think about intestinal malrotation. 2 weeks, 4 weeks, 6 weeks, you will think about, if he doesn't mention bilious or non-bilious, you will think about pyloric stenosis. Okay. And what we said about the treatment of duodenal atresia? Surgical treatment.
Duodenostomy.
Perfect. Duodenostomy. I just want to revise many times so you can fix the information inside in your brain. Duodenal atresia, duodenostomy. Okay, so next question. Dr. Basharat, whose turn now? Dr. Basharat turn? Yes. Anyone wants to participate with us can raise hand. We just started with whom started with us. Anyone new or just joined wants to participate, just raise hand and we'll give the chance to all to participate with us. Okay, Dr. Basharat, sorry for interruption.
Which of these options representing the most common abdominal emergency in children under 1 year of age? Appendicitis? No. Intussusception, intestinal malrotation, pyloric stenosis, and midgut volvulus. Under 1 year of age, I think intestinal malrotation. Oh.
Intussusception.
Or intussusception, sorry, intussusception, because after starting the feed, intussusception.
Exactly. He wants to know here if he mentioned inguinal hernia, you will go for inguinal hernia. Okay, inguinal hernia is an emergency. Once you diagnose in a child, whatever he's 1 month, 3 weeks, 4 weeks, 2 months, you'll go for operation. Okay.
Yes.
This is more common than intestinal malrotation. It's more common. Some malrotation maybe, I don't know the rate, but it's not very common. The intussusception and inguinal hernia are the more common in a child less than 1 year.
But excuse me, I want to add here that for intussusception, we don't need to go for surgery. There is this passing of air and opening this.
Okay, I want just to clear one issue. You are a surgeon, okay? When he tell you a surgical emergency means in your surgical specialist. Surgeons are not for surgery only.
Yes.
But they have their own treatment and their own diseases. But this is a surgical problem, but not for 100% need, or not for sure it needs for an operation or laparotomy, but it is a surgical problem. Yes. Okay, just to put clear. Okay, is it clear now? And they always know, they always say the good surgeon is the one when he know when not to operate.
Yes.
Okay, so this is a surgical problem.
Yes.
But you don't know, he tells intussusception, maybe ileal intussusception. Will you go for insufflation? If it is ileal intussusception, what would you go for?
Laparotomy.
No, we cannot reach there.
Yes, you can't reduce pneumatic reduction. You can't use it in ileal. You go for direct for laparotomy. Ileocecal, you have a trial pneumatic
insufflation.
Insufflation, exactly. Okay, next question. Who's there? Dr. Farah? Okay.
The parents of 1-year-old child are concerned that he develops a lump in his neck. On examination, there is a swelling in the subcutaneous tissue of the posterior triangle that transilluminates. What's the most likely cause? Number 1 is brachial cyst. Number 2 is brachial sinus. Number 3 is cystic hygroma. Number 4 is lipoma. Number 5 is pharyngeal pouch. I think it's cystic hygroma.
Yes, exactly. I can see many. CCCB, branchial cyst, sinus. No, even it is not sinus. If it will be cyst. Okay, yes, it is cystic hygroma. Yes, exactly, cystic hygroma. Okay, we have 2 types of swellings we'll face in a child. Okay, so if we have face, neck, sternocleidomastoid. Okay. Okay. So we have posterior triangle swelling, and we have anterior triangle. Most pharyngeal or branchial cyst, we will find it in the anterior triangle between the pharynx and the sternocleidomastoid. Okay. Yes. Cystic hygroma, which is a lymphatic swelling, we will find it in the posterior triangle. No branchial cysts or pharyngeal cysts, you'll find it in the anterior triangle. So when you just look, because it's a very common question in the exam, posterior triangle, it will be cystic hygroma. Cystic hygroma, swelling of the lymphatic vessels, and it will be mostly on the left side, because most of the drainage of the lymphatic system go for the left side. So you'll mostly find it on the left side in the child about 1 year, around 1 year, by the way. And I did see a case about 5 or 6 years ago, the same, like a small child, 1 year and 2 months, female, coming with a big swelling, like orange size, and it was by CT, it's proved to be a cystic hygroma. Okay, so if he went for anterior triangle, you go for branchial cyst. If posterior triangle, you go for cystic hygroma. Maybe we could find here. Okay. Congenital lymphatic lesion lymphangioma, typically found in the neck, classic on the left side, at birth, or mostly it will be before 2 years. Branchial cyst will be, this is posterior triangle. Mobile cystic mass develops between the sternocleidomastoid and the pharynx, so it will be on the anterior triangle of the neck. And by the way, it will be presented in early adulthood. Mostly it will not be present at birth, because the branchial cyst, it will be small. As the child's getting older, the branchial cyst starts to collect its secretions and start to be more bigger, and it will be more manifest at early adulthood. Clear? If anything is not clear, please just stop me and raise hand. I can clear it or repeat it again, no problem with me. Okay, next.
A 14-month-old child is admitted with colicky abdominal pain, and on investigation is found to have an ilioileal interception. What is the best course of action? You have just mentioned it, as air reduction is not an option in ilioileal. So we will go direct to laparotomy. So I will choose C, undertake a laparotomy.
Okay, perfect. Why we don't go for a trial for pneumatic or air insufflation in patients with ilioileal interception?
I don't know the explanation, so please can you illustrate it?
Because the ileocecal valve, it is a competent valve. Mm-hmm. There is no backflow of air from the colon to the intestine. It is a one-way valve.
Yes, it's clear.
You got
Thank
it?
you, Ron. Yes.
Okay. Dr. Farah, you want to ask about anything?
No, actually, I wanted to unmute the video. I accidentally clicked on raise hand. Sorry.
Okay, no problem. Okay. So the ileocecal valve will not permit you to insufflate air. But in the ileocecal or ileocolic interception, you can go for the ileocecal valve. Exactly, Dr. Hussein. Ileocecal valve will not allow air to pass. Clear? Okay, next question.
At what age should children with otherwise uncomplicated umbilical hernia be considered for surgery? After 3 years of age.
Perfect, we just mentioned it. Yeah, in Middle East, I think they start after 2 years. And by the way, this is just a broad idea about when you start to repair an umbilical hernia, but actually in our surgical field, you have to assess the opening every 3 to 6 months, and if it is more than 2 fingers, your index and middle finger, or it is increasing, or it is not decreasing up to 1 year, and you find it with the same size like 2 years, 2 fingers, so it is I think it is unlucky to close. So we can start operation since 1 year to avoid any complication like obstruction or strangulation or something like this. We wait till 2 years, maybe in Egypt and many other Arabian countries. We wait till 2 years only if we found that the opening in the umbilicus or in the anterior abdominal wall is going smaller by examination every 3 months, every 6 months, and you just follow up with the mother with instruction like try to avoid any chronic constipation or long time of constipation. You have to treat. You don't have to. You shouldn't let the child cry for a long time. If any chest infection, you have to treat it as soon as possible. So these are 3 indications you have to tell the mother: don't cry, don't have constipation, don't have chest infection or cough for a long time. So you increase the chance for the hernia to close. If a child have cough, whatever the problem, constipation for problem like Hirschsprung or any other problem, or the mother let the child cry for a long time, unfortunately this umbilical hernia will not close, because you have to decrease the intra-abdominal pressure, so give a chance to close, and mostly it will close before 1 year, sometimes 1 year and 6 months. Before 2 years, about maybe 80% of these umbilical hernia close. But I don't think we wait for 3 years, but according to the NHS and according to the Royal College, they do this operation after 3 years. So we'll go for after 3 years as they do it. But it has many, that's why I'm just telling that eMRCS for surgeon, just it gives you a broad idea. You don't go for details for these problems. Okay, so next question.
I think my turn.
Okay.
A 2-month-old baby presented with jaundice. He has an elevated conjugated bilirubin. That means there is obstruction. Diagnosis is confirmed by cholangiography during surgery. What is the best course of action? He has. We will go for the Kasai procedure. That is an Roxin Y portojejunectomy.
Portojejunectomy, exactly. This is the most common operation for biliary atresia. Child elevated conjugated bilirubin for more than 2 weeks. Indirect, direct bilirubin, direct conjugated bilirubin for more than 2 weeks. If it's continuous, so the child have a problem like obstructive jaundice, it will be mostly
biliary atresia.
Biliary atresia. And the operation, we do it what's called Kasai operation, or Roux-en-Y portojejunectomy. Okay. This exactly it's biliary tree. It will be the right and left biliary ducts, hepatic ducts, and the common hepatic, and then cystic, gallbladder, common bile duct, then go for the duodenum. Okay. What's happening in biliary atresia? All the extra hepatic will be stenosed and atresia. Okay. What you will do here in Kasai operation, you will lay these two canals. These two canals, you will do opening here. You will open this like this. All this will be removed. Okay. And you will have, and you will have an open right and left hepatic, like one canal, and you will go for the jejunum and do portojejunostomy. You will lay out all the right and left hepatic and you will go for portojejunostomy. Is it clear what about this? Yes. Clear portojejunostomy. You will open the right and left hepatic ducts. You will open them, and when you open in the liver, I think the right one is more transverse, and you'll find that you opened like a big window inside the liver, and you could just anastomose the jejunum, Rho-NY loop from the jejunum with the portal part of the ducts. Okay?
Yes.
Next question. Dr. Farah.
A neonate born at term has an episode of bilious vomiting, and an investigation is found to have DJ flexure displaced to the right. What procedure are they most likely to require? Patient has a malrotation of gut, so patient requires Ladd's procedure.
Perfect, exactly. Very simple. All questions we have about malrotation is vomiting a few hours after the birth, and the operation is Ladd's procedure. Okay. By the way, it is a band called Ladd's band. It is cut to make full rotation, and this is a band that inhibits the full rotation of the full rotation of the gut. Okay. By the way, what is the axis of rotation of gut?
Anti-clockwise.
Okay, what is the axis that the gut rotate around?
Mesentery, around the mesentery of there is an artery, superior mesenteric artery.
Superior mesenteric artery. It's a very common question and recall. Very common question and recall. The axis of rotation of gut is the superior mesenteric artery. Okay. Clear, very common question. Okay, next question.
A 2-week-old baby is referred to the surgical team by pediatricians. They are concerned because the child has a painful area of macerated tissue at the side of the umbilicus. On examination, a clear yellowish fluid is seen to be draining from the umbilicus. When the baby cries, what is the most likely diagnosis? Clear yellowish fluid is most probably urine. So
Yes.
I go with patent urachus, D.
Exactly. We have two complications with the umbilicus, or two types of umbilical fistula we have in child. The mother will come back with after birth. The two, if we have, this is the anterior abdominal wall, and this is the umbilicus. Okay, we have two problems. First problem, that in the development of the bladder, we have what we call the median umbilical ligament, which is the obliterated urachus. This is the urinary bladder. Okay, and this is what's called urachus, and this is closed and obliterated after birth, and forming what is called median, okay, umbilical ligament. Okay, if we have a laparoscopic view in the abdomen, and this is the bladder, and this is the stomach, and this is the inguinal area, we have what's called this ligament. We see it always in laparoscopy, what is called median umbilical ligament, and we have also the medial umbilical ligament and the lateral umbilical ligament. But this is the median umbilical ligament, which is obliterated urachus from the bladder. If this ligament or this urachus not closed after birth, the child will pass urine through the umbilicus. That's what we call the patent urachus, which is connected to the bladder. Clear? Clear? The other problem, what we have the intestine. We have the intestine here. Okay, and what we have, this vitello-intestinal ligament or vitello-intestinal duct. Okay, this, if it is not closed, we have three problems. We have three problems with the umbilicus. If it is not closed, we will have what is called vitello-intestinal fistula. The other thing, the other problem we will face with this duct, that it is not fully closed, and so we have what is called Meckel's diverticulum. So even it is not fully closed, it will have a fistula, or if it is partially closed, we have the Meckel's diverticulum, and it is very common to have volvulus or intestinal volvulus, because this connection will be after closure of the diverticulum or obliteration, it will be connected to the umbilicus, and it's a very common problem of intestinal volvulus in children. Many times we just open for the volvulus, we find this band as connected to the umbilical inside the abdomen with the part of the terminal ileum. But the complication what we will face here in our scenario, these two. Even we have the patent vitello-intestinal duct, which will go for the fistula, and this is a very common question in recalls, or we have the Meckel's diverticulum. By the way, all of these questions is very common in recalls. very common. Maybe 1 or 2 times per year, these questions come. January, April, or September. You have to find this question at least in 2 exams. Next question.
Premature infant, 30-week gestation, present with distended and tense abdomen. She is passing blood and mucus per rectum, and she also manifesting signs of sepsis. What is the most likely underlying explanation? She is premature. This is necrotizing enterocolitis.
Perfect. I think we talked about this, and this is a question we said about the 3 scenarios about the necrotizing enterocolitis. Next question.
I think my turn.
Who's Dr. Farah or Dr. Basharat? Dr. Basharat, تفضل.
A 1-day-old child is born by emergency cesarean section for fetal distress. On examination, he has decreased air entry on the left side of his chest and a displaced apex beat. Abdominal examination demonstrates a scaphoid abdomen, but is otherwise unremarkable. What is the likely cause? Likely pyloric stenosis, congenital diaphragmatic hernia, tracheoesophageal fistula, ileal atresia, meconium ileus. As the patient has fetal distress, there is a displacement of the there is decreased air sound on the left side of the chest and displaced apex beat. Abdomen is scaphoid, so it is the congenital diaphragmatic hernia.
Exactly. So this is part of the intestine. Okay, will
chest.
be in the chest. That's why. By the way, if you look to the other option, most other options like tracheoesophageal fistula, ileal atresia, meconium ileus, these will have distended abdomen. Even in pyloric stenosis, maybe distended stomach, you'll have distended abdomen, but scaphoid abdomen is only in congenital diaphragmatic hernia. And I think we discussed about congenital diaphragmatic hernia before in abdominal surgery, and we said what is the most common one. It will be manifest in the first day, and it will have fetal distress. Which type of congenital diaphragmatic hernia?
Posterior, Bostelics.
Yes, which one? What's name?
Bostelics hernia.
Bogdalic hernia.
Left posterior.
Yes, Bogdalic hernia. As we mentioned before, we have 2 types of hernia. Okay, just for
Morgagni.
We have Bogdalic
and Morgagni.
And Morgagni. Morgagni is good. Okay.
Bogdalic is bad.
Bogdalic is bad. Bogdalic appears early because of fetal distress, and Morgagni late in life because it is very small and less common to have any complication for the fetus. Okay, and this is emergency repair. Okay, and this is most commonly it will be Bogdalic hernia. Okay, so next question.
A 10-year-old boy is shot in the abdomen with an air gun pellet. He is concerned that he will get into trouble, and the injury remained concealed for about 10 days. Imaging using CT scanning shows that it has to be lodged in the right lobe of the liver. On examination, his abdomen is soft, non-tender, and he seems well. What's the best course of action? Operate and remove the pellet on the next emergency list. Operate and remove the pellet in the next elective operating list. Do not operate and review the patient several weeks later. Extract the pellet using interventional radiology techniques. Perform an MRI scan. So I think it should not be operated, and the patient should be reviewed several weeks later. as it is now lodged into the left lobe of the liver. It won't create any problems to the patient, and abdomen wise there are no signs that seem to be an emergency for operating in this case.
Exactly. This it is not an emergency, and it is, if you want to interfere to extract this bullet, it will be more damaging for the patient. Yes, and this is, by the way, this is applied for most of foreign bodies that go deep in the body. Sometimes you find a bullet in the thigh or in the gluteal region, and so in our practice, the best treatment not to interfere. The best treatment not to interfere, because it will be more damaging. And I think and during our study of neurosurgery, we had seen a patient with a bullet in the frontal lobe. I can remember it like yesterday. It was during our studying in the college, and our professor showed us a patient he knew has a bullet in the frontal lobe of the brain, and he asked, what's your management here, and what will you do? You do nothing. The patient is completely fine. Some problems like behavioral and some problems with frontal lobe function, but the patient is completely fine. By the way, the bullet, as it is very hot and going inside is very hot, clean internal opening and external opening. So as the patient went home just for follow-up for any further complication, he will interfere. So inside the liver, in the brain, in the thigh, in the gluteal region, in the abdominal wall, and any organ you doubt that if you start to interfere, you will do more damage and you may have more catastrophes by your interfering, just follow up for the patient. Okay. Next question.
A 4-year-old boy is brought to the clinic. He gives a history of difficult, painful defecation with bright red rectal bleeding. What is the most likely diagnosis? Fissure. C.
Yes, this is a colorectal question. We said painful bleeding, painful bright red rectal bleeding. It will be an anal fissure. Okay, and we said that painless anal bleeding, it will be hemorrhoids.
In a 4-year-old child?
Sorry?
In a 4-year-old
I'm talking
child
about a problem. No, not hemorrhoid in child. Yes.
Juvenile
in a child, it will be in a child will be a rectal polyp. But in a rectal polyp, he will give you, yes, juvenile polyp.
Exactly.
He will give you a different history. But I'm just talking about bleeding and anal bleeding, painless bright red bleeding in general. Mostly will be hemorrhoids, and if painful, it will be adult. The anal polyps, he will give you different picture, like Garden syndrome, or a mass coming out with defecation, or a red mass or something like this. We will face it in our question maybe today or tomorrow. So this is anal fissure. Next question.
When the old baby girl is noted to become profoundly cyanotic while feeding and crying, diagnosis of congenital heart disease is suspected. It is the most likely cause. This is Biliary Atresia. The options: transposition of the great arteries, coarctation of the aorta, patent ductus arteriosus, hypoplastic left heart, ventricular septal defect. Cyanotic.
Transposition.
Okay, transposition of the great arteries.
Okay. At birth. Sorry?
Early presentation since day one.
Yes, exactly. This very common, very common question and recalls. Just put this in your mind. The most common is fallots, at birth TGA. Acyanotic is VSD. Again, cyanotic, most common is fallot, but at birth it will be TGA. Acyanotic, VSD. Okay?
Yes.
Okay.
And this is the most common question coming in the exam. TGA. Many times. Mostly 90% of recalls have this question. And this is a broad idea if you want to put in your mind, but it's a little bit confusing. But just this is from the question, you just put it in your mind before the exam. Okay, if you just want what is the acyanotic, VSD, ASD, PDA, correctation and aortic valve stenosis, and cyanotic will be fallots and TGA, tricuspid atresia, and pulmonary valve stenosis. Not a very common, not a common question exam. Not so common. Okay, next question.
A 4-week-old baby is developing well and develops profuse and projectile vomiting after feeds. He has been losing weight and the vomit is described as being non-bilious. What is the most likely underlying pathology? As the patient is presented in the 4th week of life and there is not bilious vomiting, so this is hypertrophy of the pyloric stenosis.
How to diagnose?
By feeding and ultrasound, and the surgery done is Ramstein's pyloromyotomy.
Perfect. Perfect. Feeding test, ultrasound, and feeding test is more important, and then ultrasound, followed by Ramstein's pyloromyotomy. By the way, what will you see in the ultrasound?
Thickness of the pyloric channel,
Perfect.
more than 15 mm.
Perfect. More than?
15 mm.
15 millimeters.
Yes.
Okay, perfect. Thickening of the circular muscle layer, by the way. That's why
Yes.
we are transversely cutting the circular muscle layer till bulging
Mucosa.
of the mucosa. Yes. Who will read this answered question?
A newborn baby boy presents with, but it's already answered.
Yes, I know. Just in the
A
PDF
newborn
we
baby
missed the question.
A newborn baby boy presents with gross abdominal distension. He is diagnosed with cystic fibrosis and has an abdominal X-ray suggestive of distended coils of small bowel but no air fluid levels. Which of the following interventions is the first line treatment? Since the patient has cystic fibrosis and gross abdominal distension, newborn baby with features suggestive of intestinal obstruction but no air fluid levels, so patient likely has meconium ileus. So in this case, the treatment of choice is enemas with N-acetylcysteine.
Exactly.
So the
What's
option number 3 is the right.
Yes. What is N-acetylcysteine? Do you know about it?
Mucolytic.
Mucolytic. Perfect. We have another very common use in N-acetylcysteine. You know it?
In meconium ileus.
And
we can use,
another thing.
in use of N-acetylcysteines, we give in patients with respiratory diseases.
Perfect.
For,
it's very common, by the way, by its
secretion.
name. Yes, in the market, it's called N-acetylcysteine, by the way. Or we have it as like, I know it is in
Mucinate.
market here is, Yes, or I have acetylcysteine or acetylcysteine sachets. We use it for smokers with cough and sick mucus, and sometimes sick secretions in ICU patients because it's a very strong mucolytic. So that's why we use it in patients with cystic fibrosis. And what is the okay?
It's also used in tracheostomized patients for thick mucus secretions.
Okay, good, perfect. What is the test we do it for cystic fibrosis?
Chloride test, sweat chloride test.
Sweat chloride test, exactly. This is the most common question we will be asked about in our scenarios, which is sweat chloride test for cystic fibrosis, and it's meconium ileus, delayed passage of meconium in a child, and sometimes internal obstruction, and we rarely go for operation in this patient. Very rare we go for operation. Next question. Okay, go, doctor. Okay.
A male infant is born prematurely at 26 weeks gestation by emergency cesarean section. Following the birth, he develops respiratory distress syndrome and is ventilated. He begins to improve 12 days after birth. Then he becomes unwell and develops abdominal distension, passes bloody stools, and vomits a small quantity of bile-stained vomit. What is the most likely cause? I think he is premature, and I'll go with necrotizing enterocolitis.
Perfect. Yes, this is what he basically needs you to know. Premature and has abdominal problem, distension, bloody stool. So this patient will not have pyloric stenosis or H-sprung or meconium ileus or biliary atresia. He wants to know you that any premature, you just to keep in mind that this patient is susceptible for necrotizing enterocolitis. Okay, next question.
1 month-old baby girl present with bile-stain vomiting. She had an examplus and a congenital diaphragmatic hernia. What is the most likely underlying explanation? Bile-stain, congenital diaphragmatic hernia.
This is 1 month, 4 weeks. Bile-stained vomiting.
Midgut wallness. Intestinal malrotation, I guess.
Do you see atresia?
No, that is present in first few hours of the birth. So intestinal malrotation can be there.
Okay, so exactly. Okay. This is midgut wallness and malrotation. So it is malrotation in the intestine because we said it is delayed presentation with biliary vomiting. Delayed presentation with biliary vomiting. And as well, he wants you to know that malrotation is associated with examplus and diaphragmatic hernia. You have to put in your mind the patient of examplus, mostly examplus major, patient with congenital diaphragmatic hernia. This patient will have mostly a malrotation, and it is like a syndrome or triad the patient will have. Okay, and it's a very common associated problems together. Not absolutely they should come together, but he just want to put your mind to connect these 3 diseases together. Examplus, congenital diaphragmatic hernia, you have to suspect that the patient has intestinal malrotation.
Okay.
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 What is operation we do it for it?
Lad's procedure.
What is the investigation?
Contrast with ultrasound abdomen.
Upper GI contrast study, upper
And
GI contrast study, and ultrasound. What is the
ultrasound
main is
abdomen. Upper
upper
GI
contrast
contrast.
study. Okay, clear about malrotation,
Yes.
the associated surgical problems, and the investigation and the treatment. This is what they need from you about this. And the question we asked about from records, what is the axis? The axis of rotation of the gut is the
Superior mesenteric artery.
superior mesenteric artery. Very common question and recalls. Next question.
A 7-month-old girl presented with vomiting and diarrhea. She is crying and drawing her legs up. There is a sausage-shaped mass in the abdomen. What is the most likely diagnosis? Intussusception.
Perfect. Very common question. Very common presentation. 6 to 9 years. Vomiting, diarrhea, drawing her legs up from pain. Current jelly stool, red current jelly stool in the napkin or diaper, sausage-shaped mass. All these points are keywords for intestinal intussusception. Okay, so sometimes the age, crying and drawing her legs up from the pain, intermittent, the pain come and go by the way. Okay, sausage-shaped mass, red current jelly stool in napkins or in a stool. All these are intussusception key words. Next.
A 6-month-old boy is brought to the clinic by his mother. He's concerned that his testes are not located into the scrotum. She has noticed them only when he's in bath, but not any other time. What's the most likely underlying diagnosis? So the patient has retractile testes. Had it been ectopic testes, it has to be away from the path of descent. Undescent testes is never present in the scrotum. In testicular agenesis, testes is absent from the scrotum, and intersex child also does not have any testes. So the only option left is retractile testes.
Exactly.
This is the right answer.
Testicular agenesis, you'll find undeveloped scrotum as well. Okay, so if the testis is come and go and present during shower because of warm water and disappear in cold weather or come and go, so it is a retractile testis. A very common question in recalls about the site of ectopic testis and undescended testis through the pathway of the inguinal canal and scrotum. Okay, so this is the undescended testis inside the abdomen, at the internal ring, in the canal, at the external ring, or at the neck of scrotum. All this is undescended testis. But the ectopic testis, you'll find it away in the, we'll find, like he tell you, in the inguinal pouch, external inguinal pouch, root of penis, here or here. You'll find it in the perineum. Okay, all these are ectopic areas, by the way. Very common question in recalls, and he will tell you, where did you expect to find an ectopic testis? It will be mostly in the root of penis or perineum or something like this, or sometimes the question comes, where do you expect to find an undescended testis? And he will give you all the options are ectopic, except like at the external inguinal ring, neck of scrotum, deep inguinal ring, inguinal canal, These are the sites of ectopic, the sites of undescended tests. Retractile is the tests that come and go up and down. And by the way, you follow up the patient every 6 months, okay, regularly. Till you make sure even the undescended testes, by the way, till you find the testes at its normal site in the scrotum. If you need undescended testes or retractile testes up to 12 years, you start operation by this age, by the way. You start for conservative follow-up, and then you start by some medication like beta-HCG to encourage the testes to go down, and then, but you have just to follow by every 6 months or 1 year by ultrasound. And if it is not, sometimes some schools tell you can interfere after 7 years, and sometimes they tell after 11 or 10 years, 12 years. Many schools about when to interfere, and this depends on the function and size of testes in ultrasound and the progress of downward movement of the testes. Okay, next question.
Which of the following statements relating to omphalocele is false? The herniated organs lie outside the peritoneal sac. Cardiac abnormalities coexist in 25%. The cecum is usually right-sided. The defect occurs through the umbilicus. Mortality may be as high as 15%. I think A, the herniated organs lie outside the peritoneal sac.
Yeah, this is the difference between he want to inform you or tell you the difference between gastrocaseous and the exomphalus. Exomphalus, the organs inside are still contained in the peritoneal sac. Gastrocaseous, it is completely outside the abdominal wall. Okay, that's what he wants to tell you about. Difference between omphalocele and gastrocaseous. Next question.
3-day-old baby present with recurrent episode of choking and cyanotic episode. There is a history of polyhydramnios. What is the most likely diagnosis? This is esophageal atresia. Choking and cyanotic episode because polyhydramnios mean esophageal atresia.
Perfect. And this is one of the most common complications that is diagnosed antepartum by ultrasound. Now by the 4D ultrasound and the antepartum follow-up for patients, polyhydramnios is most commonly with problem like the esophageal atresia, and should be followed up by the obstetrician, or just refer the patient for a pediatric surgeon to give his appointment about the problem and the severity antepartum, by the way. Next question.
Which of the following statements related to biliary atresia is untrue? It most commonly presents as prolonged conjugated jaundice in the neonatal period. Yes, it is. Evidence of portal hypertension at diagnosis is seldom present in the UK. It may be confused with Algelia syndrome. The Kasai procedure is best performed in the first 8 weeks of life. Yes. Survival following a successful Kasai procedure is approximately 45%. No, this is the last one is untrue, because the success rate is more than 80%.
Yes, exactly. This also depends on the degree of atresia, but generally the success rate is more than 80%, and most patients will need sooner or later will need for liver transplantation by the way. So survival following successful Kasai procedure is approximately 45%. By the way, this question, which of the following is untrue, which of the following is true, which of the following is false, sometimes confusing question, but it will be clear, by the way. unless it is a strange question. But you have to arrange your mind. He will not give you a strange like term, like it may be confused with Alligeli syndrome. He will not ask you about syndromes in this question. He just maybe ask you about traits, ask you about wrong procedure for treatment, wrong diagnosis. It will be clear, by the way, but it's a little bit, it's a bit, for me, it's one of the very silly questions in the exam, to ask you what's true and what's wrong of the following, like an open question. However, most questions are repeated like this, like the same, typical like this. So when you repeat the question or solve the eMRCS many times, it will be clear in the exam to catch the answer directly after reading the answers from the first time. Next question.
A premature neonate is born by emergency C-section at 29 weeks gestation. He initially seems to be progressing well. However, the team are concerned because he has been septic, and on examination he has a swollen and erythematous umbilicus. What's the most likely diagnosis? Number 1 is patent urachus. Number 2 is patent mitlointestinal duct. Number 3 is omphalitis. Number 4 is umbilical granuloma. Number 5 is pyogenic granuloma. So the answer is omphalitis.
Yes, exactly. The patient is septic, and you have to look from where sepsis happens. So mostly here, the patient has
Umbilical vessels.
Umbilical vessels, exactly. Okay, so this will be the most common, is the omphalitis.
Yes.
What is umbilical granuloma?
Umbilical
Yes.
granuloma?
Yes.
It's a type of chronic, what's called chronic infection. Granuloma itself, it's a chronic infection, which is collection of angiogenesis of a mass outside the umbilicus. Very common to see it in a child. In the first few weeks of life, the mother brings the child until you there is a pear-like mass, or like a very small mass in the umbilicus. It's getting bleeding when you touch. It is the same like the granuloma happened in any wound unsutured, by the way. Sometimes if you have a wound in your hand, in your fingers, and some people or some patients don't like to have sutures on any base. I don't like to have suture. After a few weeks, you'll find like a small red mass that bleeds easily when you touch, like angiogenesis of a mass, like the same granuloma that's formed inside any wound during healing, but it's something bulging outside. You just can remove it by enucleation, by the way. Especially in the umbilicus, we see it very frequently in small children. You just curate it from the umbilicus and the bleeding will stop within a few minutes. Okay, it's some sort of chronic non-specific infection, or I don't like to say infection, but inflammation outside the umbilicus.
Okay, fantastic.
It's a very common problem, by the way, in surgery. You've just found the child, the mother opens the diaper and tell you the umbilicus is getting bleeding from this mass. If you just any artery or mosquito, you just clamp it and remove, it will be removed without any problem, and bleeding just pressure for a few minutes, less than 3 minutes, the bleeding will stop. Next question. Sometimes the copper sulfate is sometimes painful for child. For me, I don't do it. I just remove it and put a small piece of cotton with betadine or something like that and compress it like with a plaster until the mother will just 1 hour and remove it. You'll find the bleeding stop.
Some say that we can also apply silver nitrate to this. That
Yes, silver nitrate sometimes,
but
but
I have never heard about copper sulfate though.
many things, copper sulfate, silver nitrate, anything that makes like foreign body to stop the bleeding.
Okay.
But silver nitrate is more common, by the way.
Okay. Thank you.
Okay.
Thank you.
Sorry. Okay, next question. Who's that?
An 8-year-old boy presents with abdominal pain, a 12-hour history of vomiting, fever of 38.3 degrees centigrade, and 4-day history of diarrhea. He has abdominal pain that has been present for the past week. What's the most likely cause? Number 1 is celiac disease. So celiac disease usually has a chronic course. Number 2 is appendix abscess. It can be appendix abscess leading to pelvic abscess that can lead to diarrhea, and the patient also has history of vomiting and fever. That's also suggestive of any septic cause. And the pain abdomen that has been present for past 1 week means that the patient might have had appendicitis that might have ruptured and now causing pelvic abscess, leading to these symptoms in this patient. So number 2 should be the answer.
Okay, appendix abscess will be the answer. Other answers like celiac disease, irritable bowel syndrome, mesenteric adenitis. Mesenteric adenitis will not have this abdominal pain and vomiting. It will be with fever, okay, and abdominal pain. It will not come with vomiting. Diverticulitis, it is not the age of diverticulitis.
Patient can have mesenteric adenitis also.
But there should be history in mesenteric adenitis. There should be history of upper respiratory tract infection. Mostly.
Okay, not like this. Also,
even patient can have gastroenteritis and mesenteric adenitis as well.
But yes, no. If you have 12-hour history of vomiting,
that's
yes, this is more common with appendicitis. In gastroenteritis, you'll have more diarrhea, and the vomiting will not so severe like this. If the patient is not having anything in his stomach, he will not vomit. But the problem like appendicitis, I'm just a clinical sense, by the way. Patient abdominal pain 12 hours with vomiting. Okay, fever is 38.3. In gastroenteritis, you'll find the fever is much more higher, by the way.
High grade, yes.
High grade fever, more than 39.
Also, the abdominal pain lasts for 1 week. So long duration make appendicitis to become abscess.
Yes, it will be developed like appendicular abscess. And
plus
he will
diarrhea,
tell you.
And the duration of diarrhea and vomiting in gastroenteritis will be same.
Yes, and duration of the diarrhea will be from the start of the problem. And then start adenitis. But the diarrhea started later, 3 days or 4 days later. It will give you a fistula that is some complication developed in the terminal ileum, like retroileal appendix or appendicular abscess. And this is the most two common causes of diarrhea with appendicitis, which is a retroileal or pre-ileal or appendix or development of pelvic abscess. Okay, just a surgical sense. By the way, it is not a common question in the exam. Most confusing questions like this I didn't see in any records, by the way, last 3-4 years.
Hello?
Yes?
I can't hear you.
Now you can hear me?
Yeah.
Okay. Anyone have any problem in voice or? No, okay. So next question.
3-day-old baby developed dyspnea. Chest X-ray perform and show radio-opaque shadow with an air fluid level in the chest. It is located immediately anterior to the 6 hemivertebra. Which of the following is most likely underlying diagnosis? The options: bronchogenic cyst, congenital diaphragmatic hernia, infection with staph aureus, esophageal duplication, or hiatus hernia. I think this is congenital diaphragmatic hernia morgagni.
No,
No, it's
bronchogenic cyst.
bronchogenic cyst.
Huh?
Bronchogenic
Okay, it's
cyst.
a confusing question, by the way. Chest X-ray before shows a radio opaque shadow with an air fluid level in the chest.
Air fluid.
In congenital
Immediately on the front.
diaphragmatic hernia, the levels may be present and they are usually to the left of in the left chest.
Yeah, this is in the midline. This is a presentation, by the way, this is just a unique question, as you have no other related questions. He wants to tell you a bronchogenic cyst gives you dyspnea, and it is located in the midline. He wants to tell you it is in the midline in front of or anterior to the 6 hemivertebrae. And he didn't mention any abdominal signs, by the way. He didn't tell abdominal distress. He didn't tell scaphoid abdomen. He didn't tell lung agenesis or lung hypoplasia or something like this. He just mentioned radio opaque shadow with air fluid level in the middle of the chest. Yes. Okay, and this is a bronchogenic cyst. I didn't see also it in recalls, but you just put it in mind. It may be one of new question last few years and maybe missed in recalls by anyone. But it's not very common. But in Bucdalic or Morgagni hernia, the question will be clear, as we said before. On the left side, or small or presented scaphoid abdomen, problem with feeding, respiratory distress, early in life, the fetal has distress and scaphoid abdomen and hypoplasia of the lung and loops of intestine in the chest. But he just said a radio opaque shadow. By the way, he said here radio opaque shadow, and the other side in genital diaphragmatic hernia, he tell you intestinal loops inside the chest. He will not tell you a radio opaque shadow.
Yes.
Okay.
Confusing question, by the way, but it is not very common. Next question.
Which one of the following is least associated with tetralogy of Fallot? There is tetralogy of Fallot. There is right ventricular outflow tract obstruction. Yes, overriding of aorta. There is no left to right shunt. There is always right to left shunt, mostly.
Exactly.
There can be left to right shunt also.
Mostly there is right to left shunt.
Mostly there is right to left shunt. Right.
Yes, can be, but if there is, I think pulmonary, least pulmonary stenosis. Mild pulmonary stenosis. Yes, exactly. Yes. As I remember, it is almost with tetralogy of Fallot. You have a severe pulmonary stenosis, so you have right to the left shunt because the pulmonary stenosis. But when the pulmonary stenosis is less, you may have the same right to left or left to right, or sometimes more the left to right shunt if you don't have any pulmonary or very mild pulmonary stenosis.
And in that case, patient can also have cyanosis.
Can have cyanosis. If there is left right shunt, the patient will have cyanosis. But
usually it does not.
Yeah, but cardiac problems, surgical problems are not very common, but I think I did see this once before, tetralogy of Fallot, that have, he will ask about the shunt or one of the 4 things about the criteria of tetralogy of Fallot. But most common question more than 90 to 95%, he is asking about the most common cyanotic congenital disease early in life or presented in the first day of life, which is the TGA. This is the most common question. Next question.
A 2-year-old accidentally inhales a peanut. They arrive in the emergency department extremely distressed and cyanotic. Imaging shows that it is lodged in the left main bronchus. What's the best course of action? Arrange bronchoscopy on the next scheduled operating list. No, manage conservatively. Treat in the emergency department under sedation. Arrange immediate transfer to the theater for bronchoscopy. Attempt to remove in the emergency department. So attempt to remove in the immediate transfer to the theater for bronchoscopy. And ideally it should be taken with the rigid bronchoscope.
Arrange immediate transfer to
To the
theater
theater
for bronchoscopy.
bronchoscopy.
Exactly. This is an emergency problem. Okay. And the child should be treated immediately in the theater because you are talking about the vital organs like the lungs and respiration. So you can't wait for the next list, or you just want to wait, or sedation. No, and you can't do it in emergency department. This is one of the operation you can't go through in the emergency department as well. A very common question on recalls, asking about if a child swallow a foreign body, where it's most commonly to find it?
Right
lower.
main bronch. Right
Lower.
Yes, right lower.
Right lower.
But
It
in
is
this scenario,
dependent.
we cannot use a rigid bronchoscope because the foreign body is in the left main bronchus. The rigid bronchoscope cannot turn because
Yes,
left is not
exactly.
straight.
Yes.
Here is the most common question. This is the foreign body. Why? Because the right main bronchus is more in line with the trachea.
It is
Trachea.
actually,
So
it looks like the continuation of the trachea. It is more
Exactly the same. Especially the right lower loop.
So in this case, we should use a rigid bronchoscopy.
If right, yes, rigid, but if left, no, only
Exactly.
Flexible. You will not have any question about rigid or flexible, by the way.
Yes.
The most common question here is this question, that it is an emergency, and the other one is where you can find the foreign body most commonly, which we answered, which is right lower loop. Next question.
A 3-year-old boy is brought to the clinic with symptoms of urinary hesitancy and poor stream. Which of the following is most likely underlying diagnosis? Posterior urethral valves.
Posterior urethral is a very common question in pediatric urologic problem, which makes a very poor stream or weak stream sometimes, and makes a very recurrent UTI infection as well.
And bilateral hydronephrosis.
Yes, bilateral hydronephrosis, exactly.
And in females, vascular reflex.
Sorry?
In females, most common cause of UTI is vascular reflex. Female child.
Vascular reflex?
Yes.
Okay. I didn't see this question in recalls, or just general information?
General information.
Yes. Okay. Next question.
A male infant born at term by normal vaginal delivery is well. However, 72 hours following delivery, he has still not passed meconium. On examination, his abdomen is soft and not particularly distended. he has a normally sighted anus. What is the best course of action? Not past meconium. This is Hershey's-Brand disease. The options: undertake a colonoscopy and ban colonic biopsies. No. Undertake flexible sigmoidoscopy and left-sided colonic biopsies. Undertake full thickness rectal biopsy. Yes, undertake full thickness rectal biopsy. Undertake lobe colostomy. No, undertake lobe ileostomy. Answer is C. Undertake full thickness rectal biopsy. This is Hershey's-Brand disease. Absence
Yes,
of
exactly.
the segment of the colon.
What will you find in the biopsy?
A ganglionic segment.
A ganglionic segment. And this segment is dilated or spastic?
Dilated.
No, spastic. This one will be spastic
Spastic.
because no
Spastic
ganglions in the
segment.
myotic plexus.
Spastic segment, because it's a
Right.
very common question. Spastic segment, okay. The absence,
Yes.
so in the full rectal biopsy, full thickness rectal biopsy, absence of myenteric ganglion or neural plexus, and this segment will be spastic, followed by a dilated segment of normal ganglion.
A male infant
Myenteric
is
and Meissner's plexus. Yes, exactly.
A male infant is born by spontaneous vaginal delivery at 39 weeks gestation. He is well after the birth, established on bottle feeding and discharged home. His parents are concerned because he subsequently becomes unwell and vomits a large amount of bile-stained vomit approximately 2 days after discharge from the hospital. On examination, he looks ill and his abdomen is soft and not distended. What is the most likely cause? As he is 39 weeks. He is 2 days after the discharge. I think this is duodenal atresia.
No, intestinal malrotation with volvulus. Intestinal duodenal atresia just few hours after the birth.
Okay, thanks, Dr. Farah. As we said, the patient with duodenal atresia will not be discharged home. This
Yes.
problem will appear in the first feed of life and the first feeding few hours. The patient, as he told you, the patient went home because no discharge for any fetus unless the mother feeds the child, and then will be discharged. And then the problem will appear in the 3rd to 7th, in the first week of life, and mostly after the 2nd or 3rd day. Okay, as the child went home and come back, so the problem start to appear, and this is an intestinal malrotation. I just don't want anyone to forget it again. The child with duodenal atresia will not leave the hospital, will not be discharged home. Okay?
Yes.
What is the operation?
Lad's procedure.
Lad's procedure.
And for duodenal atresia?
Duodenal
This is Kasai's procedure. Duodenal atresia, no, duodenostomy. Duodenostenomy.
Okay, and for pyloric stenosis?
Ramstead's pyloromyotomy. Pyloromyotomy.
And for achalasia of esophagus?
Poems. Heller's myotomy.
Heller's myotomy.
Or per olar endoscopic myostomy.
Heller's, it's a very common one. The same idea like Ramstead, by the way. Okay, the same idea. We just got the spastic or.
In achalasia cardia, we can also do per olar endoscopic myotomy, minimal invasive technique.
Sometimes, yeah. Okay. Next question.
A 1-year-old child has been unwell with sore throat and fever for several days. He progresses to develop periumbilical abdominal discomfort and passage diarrhea. The pediatricians call you because the ultrasound has shown a target sign on the right side of the abdomen. What's the best initial course of the action? Obtain IV access, administer fluids and antibiotics. Undertake urgent fluoroscopic reduction. Undertake urgent hydrostatic reduction, undertake a colonoscopy, undertake a laparotomy. So the patient has been unwell for several days. First of all, we need to stabilize the patient. For that, we will obtain an IV access, administer fluids and antibiotics. So number one should be the answer.
Yes. Who answered C is right also, but here just put in mind or take care from initial and what is the different treatment. Initial course here, it will be stabilize the patient. Stabilize the patient. Initial course, stabilize the patient, and different, it will be urgent or prepare the patient for hydrostatic reduction. Next question.
A 2-year-old has a history of rectal bleeding. The parents notes that post defecation, a cherry red lesion is present at the anal verge. What is the most likely diagnosis? Juvenile polyp.
Exactly. Villus adenoma. No.
No. Juvenile polyp. Villus adenoma is in adults.
Okay. It is the villus adenoma is very aggressive adenoma, by the way.
Yes.
Okay. So I'm sure it was just a keyboard mistake. Okay. So this is juvenile polyp. So this is the history of a juvenile polyp in a child. He will tell you there is a mass or cherry red lesion in the anal verge. So this is juvenile polyp. It will be very clear, by the way. Okay, next question.
Which of the following is not a feature of esophageal atresia in neonate? Not a feature. High incidence of polyhydramnios, yes. Risk of recurrence in subsequent pregnancy, this is wrong. Distal tracheoesophageal fistula is the commonest variant, yes. High incidence of associated imperforate anus. Absence of gastric fluid on antenatal ultrasound. Risk of recurrence, this is not true, not a feature.
Yes, exactly. This is an isolated problem. Has no high recurrence rate or congenital problem to the recurrent in subsequent pregnancy. Okay. Next question.
A 12-day-old infant is brought to the emergency department by his anxious mother, who noticed that he has developed a right side groin swelling. On examination, the testes are correctly located, but it is evident that the child has a right side inguinal hernia. It is soft and easily reduced. What is the most appropriate management? Surgery over the next few days, reassure and discharge, no. Surgery at 1 year of age, no. Surgery once the child is 6 months old, no. Application of a hernia truss, no. Surgery over the next few days, A.
Exactly. No.
Yes.
We said in the start of our discussion that emergencies in child, surgical emergencies in child less than 1 year is inguinal hernia. Once you diagnose, you have to prepare the patient
for herniatomy.
Repair. Exactly. And herniatomy, you do it through
inguinal
or scrotal approach.
Inguinal approach.
And to go for herniatomy. So surgery over the next few days. The next available list, by the way. This is the next available list. Next question.
A 6-year-old child develops ballooning of the foreskin on maturation and is brought to the clinic by his anxious mother. On examination, the foreskin is not retractile but otherwise normal. By what age are 95% of all the foreskins retractile? 16 years.
Yes, exactly. As we
I
know
just
that in
remembered
UK, they don't do circumcision, and it is like a criminal act there, unless it's indicated by any surgical problem, like recurrent balanitis or balanoproscites or proscites or something like this. Okay, so they just wait for the child to be 16 years old, and they expect that until puberty, they expect that all the foreskin will be retractile during erection. Okay.
Okay.
By the way, this year, the first in eMRCS Part B, last few exams before they stop exams in March, they start to introduce new session about balanitis and proscites and paraphimosis, phimosis and balanitis and balanoproscites, by the way. They just ask about the definitions and what to do. Okay, this is a new station, but it was a pilot station, not a fixed station, but it will sure start with pilot station and to be a fixed station afterwards. So just put in your mind, balanitis is inflammation of the glans penis. Okay. Posthites is inflammation of the foreskin. Posthites. And balanoposthites is inflammation of the glans and the foreskin together. Paraphimosis from its name, it's retraction of the skin, of the foreskin, proximal to the glans, and it can't be extended again due to inflammation or stricture by a band or by fibrosis or by swelling and edema. Okay.
Okay.
And phimosis, which is one of the very common complications that requires early circumcision, is stenosis of the foreskin that can't be retracted over the glans of the penis. This is the main definitions you want to hear from you. Okay, clear these definitions? Clear?
Yes.
Okay, next question.
A neonate is noted to have bowel obstruction. What is the most likely cause? Imperforate anus, no. Meconium plugs, maybe. Clonic atresia, no. Anal atresia, no. Sigmoid volvulus, no. So meconium plugs.
Yes, this is the first common cause of bowel obstruction in a neonate. Imperforated anus, it will be a manifest problem. You can see it. Clonic atresia, it's not a very common problem. Anal atresia, you will see it and it will be manifest. Sigmoid volvulus, it is not the age of a sigmoid volvulus. And meconium plug, it's a very most common problem in a child or a neonate with bowel obstruction. So meconium plug is the most common cause. Due to cystic fibrosis. Sorry?
Why we exclude imperforate anus?
Imperforated anus, to have a bowel obstruction for imperforated anus, you see the patient, okay? It will take long time in a child. Maybe it is a neonate, not that has bowel obstruction. Neonate means in the first few, I think he's talking about a newly born child, and you have this. And imperforated anus is not a common problem, because he is asking about the most likely cause, and imperforated anus is not a very common cause. The same like colonic atresia and anal atresia. We're asking here the most likely cause, but all these are causes of intestinal obstruction. But what is the most likely cause?
Meconium
plugs.
Okay.
Okay, sigmoid volvulus is common in
Adults.
elderly age. Yes, elderly age. And meconium plug is due to?
Cystic fibrosis.
Cystic fibrosis,
And
most
what
commonly.
is the test? What is the test?
Sweat chloride test.
Cystic fibrosis.
And what is the treatment options?
Enemas with N-acetylcysteine.
Okay, perfect.
If the patient does not have distension.
Yes. Okay, next question.
A female neonate who is born at term has an episode of bilious vomiting. An upper GI contrast study is performed and show duodenal flexure lies on the right of the midline. What is the most appropriate course of action? This is intestinal malrotation, and always we say undertake last.
Exactly. Lad's procedure is the most common operation. Next question.
An 18-month-old boy is brought to the emergency room by his parents. He was found in bed with a nappy filled with dark red blood. He is hemodynamically unstable and requires a blood transfusion. Prior to this episode, he was well and no prior medical history. What is the most likely cause? Necrotizing enterocolitis, anal fissure, esophageal varices, Meckel's diverticulum. Yes, it is Meckel's diverticulum, as painless bleeding is there.
Okay, so this is by
Yes,
and this is by exclusion. We said necrotizing enterocolitis. He will tell you, he tell you the patient with no prior medical history. Necrotizing in premature child. This child is 1.5 years. So we got away from the intussusception, and intussusception will be red current jelly stool. It will not be a dark red stool. So it is a contained blood. So it may be from the upper GI tract or from a Meckel's diverticulum. So anal fissure, it will be red fresh blood and painful defecation. Esophageal varices is not a common in this age. Crohn's disease also is not a common in this age. It will be more than in early adulthood. So here he want to tell you that I think we don't need for this. Polyps, Meckel's diverticulum, inflammatory bowel disease in a child older than 2 years. And I think it's more than this also. Intussusception will be in the first year of life. He will not give you any question about intussusception in the more than 2 years, by the way. The question will be clear. A child 6 to 9 months with sausage mass and red currant jelly stool and pulling legs upon his tummy or his abdomen. Next question.
What is the investigation of choice to look for renal scarring in a child with vascular-ureteric reflux? Abdominal X-ray, ultrasound, DMSA, CT KVD, and MCU. So it is a DMSA. For diagnosis,
Okay,
we need MCU.
Okay. DEMSA scan is the most common test we do for vascular-ureteric.
No, for renal
reflux,
scarring.
for renal scarring,
For renal scarring.
for renal scarring, and for pelviureteric junction, PUJ obstruction, by the way. DGPA will use DEMSA scan. By the way, CT give us the same results. CT give us the same result about renal scarring, But if we didn't do CT, we always start with DEMSA scan. I think we discussed about this in urology before.
Yes.
Next question.
Which of the following statements relating to necrotizing enterocolitis is false? It has a mortality of 30%. Most frequently presents in premature neonates less than 32 weeks gestation. Should be managed by early laparotomy and segmental resections. Yes, it's C. As early management is medically. We go for laparotomy only in complicated cases.
Perfect. This is the third question we said about. Next question.
4-year-old boy is brought to the clinic by his mother. He had a swelling in his right hemiscrotum. On examination, it transurinate brilliantly. What is the best course of action?
Okay, what's your diagnosis?
Hydrocele.
Yes, exactly. And what we do for hydrocele?
He is 4 years. We will do the inguinal approach.
Yes.
Ligation of the bottom process vaginalis via an inguinal approach.
Perfect.
Yes.
Yes. We don't do Jabulai or Lourdes for a child.
Yes.
We just ligate. We just ligate the processor vaginals. Okay. Jabulai and Lourdes operation, we do it through scrotal approach for adult patients. Adult patients. Okay. Next question.
A 1-day-old neonate is developing increasing problems with feeding. On examination, she has a pansystolic murmur and her forearm have not developed properly. What is the most likely underlying problem? Oh, this is vector. Like there will be esophageal atresia.
Esophageal atresia. Vectoral with esophageal atresia.
Esophageal atresia.
Yes. Okay, next question.
A 6-week-old baby boy is brought to the clinic by his mother. She is concerned because although the left testis is present in the scrotum, the right testis is absent. She reports that it is sometimes palpable when she bats. On examination, the right testis is palpable at the level of the superficial inguinal ring. What's the most appropriate management? So in this patient, we do not discharge the patient, races in 5 years, no laparoscopy. We reassess the child every 6 months, and if the patient is symptomatic or any pain, then we plan for surgery or something like that. Otherwise, we keep the patient on follow-up only. So this is fourth option.
Okay, so this is retractile testis, and yes, it is mostly it will descend by itself by early adulthood. By the before 7 years, mostly it will be completely scrotal.
Yes.
Next.
An 8-week-old infant is brought to clinic with a history of 18 days of jaundice. The mother is breastfeeding. He was a full-term baby. There is no family history of liver disease. What is the most appropriate next step? Liver ultrasound, unconjugated bilirubin measurement, conjugated bilirubin measurement. reassurance discharge, ERCP. Jones, I'll measure bilirubin. Bilirubin, conjugated bilirubin measurement.
Exactly.
So
More
exclude
than
the obstructive zones and biliary atresia.
exactly more than 2 weeks, you have to measure the direct or conjugated bilirubin because you fear of biliary atresia. Next question.
A baby boy is born by elective cesarean section at 39 weeks gestation. He initially seemed to progress well and is discharged from hospital the following day. The parent brings the child to the clinic at 10 days of age and are concerned at the presence of profuse and foul-smelling discharge at the site of the umbilicus. On examination, the umbilicus has some prominent granulation tissue. When the baby cries, a small trickle of brownish fluid is seen to pass from the umbilicus, most likely cause. This is patent intestinal duct.
Right.
B.
Are we connected?
Yes. No.
I guess Dr. Rami has a connection problem.
Yes, he left the meeting.
He left the meeting.
Anyways, the answer to the previous question was patent
Yes, it is
vitello.
correct. Yes, it is correct.
He will come back or he will need to do another Zoom meeting.
I think let's wait for a few minutes. Maybe he comes back.
Yes, let's give him 2 or 3 minutes.
Maybe he has some call or something to attend to. That's why he left.
Do you have any idea about the next exam date or they didn't mention?
As
I
they
don't
said,
think so.
that might be in September.
As the scenario goes, I don't think so. Maybe Jan.
Why?
The Prime
Why
Minister
do you
of Britain,
think so?
the Prime Minister of Britain, he told that maybe the lockdown can continue up till 6 months.
Because things are not so good.
Sorry for this disconnection. I just the router has switched off.
It's fine.
Never mind, Dr. Rom.
Okay, I think we just have about less than 5 questions. I think so. Wait. Yes. Okay, this is a question. We stopped, yes? Hello?
Yes.
Yes, sir.
Yes,
This is the question. Okay. So the answer was patent fetal intestinal duct. Yes? This is the question we stopped at, yeah?
yes. Okay.
Okay. Sorry for interruption again. Next question.
A 12-year-old boy is brought to the clinic with history of weight loss and bloody dysentery. Abdominal examination is unremarkable. What is the most likely diagnosis? A. Colorectal cancer. B. Inflammatory bowel disease. C. Irritable bowel syndrome. D. Is Munchausen syndrome. And E. Viral gastroenteritis. He has a bloody diarrhea and there is history of weight loss, 12 years. I will go for inflammatory bowel disease.
Yes, exactly. It's a very common problem with adults. As I told you, they said more than 2 years, but I tell you it is more than this, and it is associated with weight loss as well. Irritable bowel, no. Colorectal cancer, it is not the age. Munchausen or Munchausen syndrome, I don't know what is it. Viral gastroenteritis will not be associated with bloody diarrhea. So
Munchausen
it is
is
inflammatory.
basically, in this syndrome, basically the patient feigns for a disorder.
The patient is?
Feigns for a disorder. For example, like students, they to escape from exams, they feign a disorder, like they put something under their armpits or something like that, so that they can have high temperature and then they can escape their exams. Or many in many occupations, to get leave from their superiors, they do this. Or females, to attract attention from their from her husband or people in her family, so they feign a disorder that's known as Munchausen's proxy disorder.
Okay.
I had read it in psychiatry.
Yes, thank you. Next question.
A 3-year-old child inserts a crayon into her external auditory meatus. Attempts to remove it have not been successful. What is the best course of action? Number 1 is manage conservatively. Number 2 is remove in the emergency department under sedation. Enlist the help of additional staff members to restrain the child before attempting to remove it again in the emergency department. Operate on the next emergency operating list. And number 5 is transfer immediately for emergency surgery. So this is not an emergency yet. We have to retrieve this. So we will operate on the next emergency operating list. I think so. I don't know. Maybe.
Yes, exactly. We can do it under sedation. It is not so urgent, but it is an emergency, like appendicitis. Like we do it the next emergency list, but not in an ER or in something like this. We have to do it under complete GA anesthesia. Next question.
Which of the following statements relating to Hirschsprung disease is false? It's more common in males, yes. Is typically associated with dilated aganglionic segment of bowel? No. The aganglionic segment is the stenotic one, so it's B.
Yes, exactly. As we said, the aganglionic segment is spastic segment, not the dilated segment. Next question.
7-year-old boy present with 3-day history of right iliac fossa pain and fever. On examination, he has temperature of 39.9. His abdomen is soft and mildly tender in the right iliac fossa. What is the likely underlying diagnosis? Appendicitis is straightforward.
It is appendicitis?
I think so. Yes, right iliac fossa, pain, high temperature.
Yes. But the abdomen is soft. The abdomen is soft and mildly tender, and the patient is 39, and the patient is almost 40. What do you expect for the appendix?
Very high temperature with mesenteric adenitis, you mean?
Okay. In practical diagnosis of appendicitis, you have to correlate many things: the fever with the pain and the symptoms of the patient. Okay. So if a pediatrician sent you a child and he tell you, doctor, he has a tenderness in the right iliac fossa, and by the way, you will find many referrals from pediatrician about a patient having abdominal pain and tenderness in his abdomen. But you just ask the doctor or ask the pediatrician, what is the temperature? If he tells you the temperature more than 38.5 or 39 or something like it, and you just put your hand on the abdomen. If it is lax or mild tender or soft, so it is not appendicitis. The source of fever is not the appendix. You can imagine a patient has a fever 39 or 40 because of appendix. You should find the local signs is very, very aggressive to be related to the fever. Is it clear?
Yes.
Again, if the problem is from the appendix, so what should be more prominent? If you find a fever 39 or 40, so the local signs, it will be related to the general signs. So you should have a perforated appendix or a highly inflamed appendix. So you should find rigid like abdomen and severe tenderness and severe rebound. But if the fever coming from, I just want to tell you, even sometimes you find the patient has a sore throat or a follicular tonsillitis and has abdominal pain, and he's 40, and you find the abdomen is lax. You just put your hand. Is this lax abdomen can be correlated with the very high fever? No. If I saw the fever 39 or 38.5 or 40, I should expect before I put my hand on the patient that I found rigid or board-like rigidity on the abdomen. If not, so it is not appendicitis. Clear?
Okay, clear.
Very common in practice. So it is mesenteric adenitis due to any viral infection, sore throat, or anything like this. By the way, they always said with appendicitis, there will be no or very mild fever, by the way. With acute appendicitis, you will find the temperature about 37.5, 37.6.8. More than 38, so you have a complicated appendicitis. And mostly you will find a board-like rigidity or severe rebound and severe peritonealism, more than 38. Because normally the appendix make a very mild fever, about 37.5, 6, 7, something less than 38. More than this, and by the way, also mild tachycardia. So you'll find the child have maybe 85 to 90 pulse rate, beats per minute. If you find more than this, more than 100 or more than 110, for sure you have a complicated appendicitis. If the abdomen is lax, so it is not the cause. Appendix is not the cause of this fever or this tachycardia. Okay. Question.
A four-year-old is admitted with right iliac fossa pain and is due to undergo an appendectomy. The nursing staff would like to give the child the nursing staff would like to give a child an infusion of intravenous fluid while waiting for theater. Assuming electrolytes are normal, which of the following is an appropriate fluid for infusion in this situation? 10% dextrose solution, 0.9% saline solution, 0.45% saline and 5% glucose solution. Gelofuscin, none of the above. As the patient is 4 years and he's waiting for appendectomy, I think 0.45% saline and 5% glucose solution will be given.
Other answer?
Electrolytes are normal.
B.
0.9% saline solution.
0.9%
Sorry,
saline.
0.9% saline solution.
Normal saline. Normal saline.
Doctor,
0.4.5 by
less than
Sobay and
5%.
5% glucose solution. We always give this in patient, diabetic patient, by the way, intraoperative. The most appropriate for them is 0.45 and saline. What we call half saline. Okay, this is
And
very
this is
common with diabetic patient. What
in
he want to
children
tell
less
you
than
here,
1 year.
yes, what he want to tell you, children less than 1 year, yes, sometimes we give it 0.45%, and he want to tell you that more than 1 year we give normal saline, less than 1 year we give this cocktail, and in neonates we give
10% extras.
10% good extras. That's what he wants to know, by the way. Okay, but you will find 0.45 more common. You will find it part B in management of the intraoperative management of diabetic patients.
Yes.
Last question.
A 4-year-old boy presents with the symptoms of dysuria in urinary frequency. A urine dipstick which is positive for blood and nitrates. A UTI is suspected. Which of the following strategies is the most appropriate? Number 1 is watchful waiting. Number 2 is cystoscopy. Number 3 is DMSA scan. Number 4 is CT scan of pelvis. Number 5 is renal MRI. Maybe DMSA scan to see for renal scarring.
I guess A, watchful waiting.
I don't remember. Maybe if patient has posterior urethral valves, and that can lead to renal
But
scarring.
this is not a recurrent.
DMSA.
He didn't tell you the recurrent.
Okay, right. So watchful waiting. I'm sorry.
Yes, this is a normal UTI for a child. He didn't tell you recurrent or any other problem or pain or recurrent pain or recurrent infection. So this is a simple UTI in a child or any person. So what you do, just you made the urine test and you watch waiting, which will be mostly with conservative treatment.
Okay.
Okay.
Yes.
That's all. We finished. Thank you.
Thank you.
Today we finished all
Thank you very much.
pediatric surgery issues in eMRCS. I hope there is no problem with the recording, and I will send you in the group as soon as it is processed. Okay, I'll stop recording now.